Welcome to the Reprofiles, where infertility meets injustice and nothing is off limits.
We're two nurses. We're certified reproductive health advocates, and we're here to tell you everything they didn't.
From the broken systems to the heartbreak left behind, we're here to connect the facts, the policies, and the pain.
Because silence isn't safety, and we're done being quiet.
This is the Reprofiles.
Infertility, injustice, and all things nobody warned you about.
Hey, welcome back to the Reprofiles. I'm Anne-Marie Luft, your fertility nurse slash advocate, and my partner here is
Elizabeth Lee, your other host of the Reprofiles, and as I like to say, friendly neighborhood nurse congressional candidate. That's not a mouthful at all. But today, we're very excited to bring a very trusted voice in a space that Anne-Marie and I spend a lot of time talking about, and that is the mental health and infertility space. And so Dr. Julie Bindeman is with us. Anne-Marie and I met Julie as the three of us were all a part of the inaugural American Society for Reproductive Medicine's Policy Advocacy Fellowship. There's a lot of letters, so I just kind of call it that. But the three of us were lucky enough to come together with other people in the space and talk about how we can take advocacy to the policy level. So Anne-Marie, do you want to talk about how you remember meeting Julie? Because I feel like we all met on a Zoom, right?
yeah, we all met on Zoom. And I was able to I've presented with Julie twice now. We did our
Right.
we did our primed capstone project together, and we have been told by people that we should have taken our show on the road. So
I
I'm
would
going to say
second
that was
that.
a success.
I
Yeah.
agree.
And then we also presented this year, this past ASRM, together as well. And it's amazing because she just has so much knowledge and just can bring so much to the table. So it's amazing. And thank you so much for being here, Julie. So can you just tell us a little bit about yourself?
Sure. So my name is Dr. Julie Bindeman. I am a reproductive psychologist and I practice outside of the DC area, but I am able to practice within telehealth in the majority of the United States. So that's really cool. I like to say I came to my work honestly. I had my own reproductive journey, and like so many of my colleagues, that even made me aware that this was a thing, this was a field, and I haven't looked back. I've been an advocate for the last, 16 years, and primarily within the space of reproductive health, occasionally for psychology, but primarily within the reproductive health spectrum.
And how do patients generally find you? Are you finding that providers in the fertility clinic are referring to you, or are patients having to find you on their own?
So what I'm seeing nowadays is most clinics will be like, here's our list, pick from our list. And I don't know how updated the lists get. There's one clinic that is like the lone holdout that is privately owned, and, love them. They will by name refer to me. So it'll be like they're sitting with someone and be like, hey, so you need this consultation. Here's one of the people we really like. So that's been good. And I'm at the point in my career, which is lovely, where a lot of it's word of mouth.
Nice. Yeah. So, Julie, I know that, working in the fertility clinic myself, when I first started, I was in the third party department. All of our patients who used donors or who used gestational carriers, those are the people that we would typically refer, to you and or someone in your position. But then I started working in the other part of the clinic where I was working with, like, I guess you could say, quote unquote, regular patients. And it didn't come to me that often. I'm like, oh, I should have referred them to someone because I think they're having a hard time, they're struggling. What's some of the advice that you can give us professionals as far as, like, when do you think is the best time to come and see you?
I think there's never a bad time.
Mm-hmm.
Although the one bad time is, and I get these calls all the time, when someone is like 34 weeks pregnant, has never dealt with other reproductive trauma, and is about to give birth for the first time. And they're like, so I have all of this other trauma. Can we deal with it before I give birth? And I'm like, we'll do our best.
Mm-hmm.
So that's the only time when I'm like, no, if you called me earlier, we could have done so much more.
Do you think it would be fair to I mean, I would never say mandate, but like to refer every patient through a mental health provider. I mean, when I was building the last big IVF program I built before I went on my little political hiatus here, mental health was an intentional piece of every part of our program from like intake forward. So, why don't, or so I guess maybe I'll ask you the question, why do you think we don't have it as just like a standard of the care? Right? Like we know for IVF, you need a certain workup, you need certain blood tests, you need certain analyses and whatnot. Fine. And you need to talk to Dr. Bindeman. Why do you think that would be a good idea?
So there's two things. One is history. So it actually used to be that when people were going through IVF, they had to meet with a mental health professional, but it was much more of a gatekeeping thing. Are they mentally healthy enough to do this? And we're not gatekeepers. I never think of myself as a gatekeeper. I can give recommendations, but whether people go with it or not is not in my hands. I think the second piece of it is that we are not a moneymaker. And so if you're focusing on what return is for investment, we're not it. And so what I've seen more and more, and it's really unfortunate, in fact, it kind of reminds me of like your disasters episode. But for mental health, we have different kinds of disasters. And what is happening more and more is that people are going to the big practices that are very inexpensive and they don't do a good job. So that's much more for third party work. I don't know that these practices do a whole lot of therapy, but I've been on the other side where people are like, yeah, my clinic won't accept this. They asked us to redo it. So can you redo it for us? Yeah, sure. But then so it's disappointing and it ends up costing the patient more money. But I can appreciate what an expensive endeavor IVF is, particularly if you don't have any insurance coverage of it, or it's like insurance that just covers your workup, which is like, really? So I think, again, it's like, I think people tend to think of it as like one more thing. It's one more obstacle, one more hurdle. And while I'm sort of in this venting or talking space, I hear a lot too from same-sex couples. There is a recommended consultation that anyone who is using donor gametes needs to do in order to really understand what they're taking on emotionally. It is not all these things go away once the baby comes. It's how do you connect to that child? And do you talk to that child about their origin story? And when do you do that? How often do you do that? Who else might know? So there's all these different factors around it that we're just focused on the baby. We're not focused on necessarily all these other considerations.
Yeah, I remember whenever I would refer people in the third party space, particularly the LGBT community, I kind of felt like a pushback. Like they felt like they were being targeted. Like, well, we have to use donor. We have to use a carrier. And why do I have to do this? And I think when first people hear about it, this consult, hey, there's this consult you have to do, they think, oh, is a consult for, am I going to be a good parent? Or are they going to my home and to make sure that I have all that? And I always have to explain to them, no, it's not. It's just they want to talk to you about the process. They want to talk to you about disclosure and at what ages and how to disclose at different ages and talk about it at age appropriate levels and things like that. And sometimes they would feel more comfortable. But I would tell you that probably 9 times out of 10, the people that would go through this consult for third party, they always came back and were like, that was amazing. I learned so much. And thank you for providing that. I didn't really get pushback after the consult. They were usually very happy with getting an explanation, getting more into detail about that.
And it's interesting too. There's some newer research that University of California, San Francisco is doing because they have all the great research, I believe. No, other places are good too. But a colleague of mine was doing a qualitative study with same-sex parents and this whole idea of consultation and what the experience was like for them. And even though I say at the beginning of all of mine, I'll start with, what did your clinic tell you about this meeting? And most of the time, clinics are still using evaluation. So they're coming in thinking it's a fitness for parenting or kind of thing. And yes, oh my gosh, that would be awful. So after I hear what they've heard, and sometimes I'm like, oh, good, your clinic did good job explaining this to you. But most of the time, it's an evaluation, and I have to do it. So inevitably, at the beginning of every single consultation I do is I want to state really clearly, I am not evaluating you. I don't have the training to do fitness for parenting evaluations. So I would be way out of my scope if that was something I'm doing, but it's not. You two have decided to be parents. I'm good with that. And then I add a little joke about like, unless you tell me that like you love to ritually kill kittens or puppies and you can't wait to bring a child to hear that. It's so outlandish that they're like, okay. That tends to make people more comfortable. That being said, and I've had people who have said to me afterward, "Oh my gosh, thank you so much. This was so much better than we expected." But what my colleague found in her research is, particularly with same-sex couples, they have had a lot of stigma around accessing healthcare. And one of the leftover things of it is this idea of, I need to perform so that I can get to next steps. And so even if they hated it, they're going to be like, yeah, that was great, because they don't want to fail. And they look at it as that.
I think about all the things that's like our little tagline in this show is like all things no one told you about. And I think of even like I think all have similarly aged kids, right? Ish. So I think about, and I have like a big gap to my oldest and my youngest. And I think about all the lessons I learned as a parent and what type of parent I was to the oldest versus I mean, there's just so much
So
that you learn drinking from the fire hose. And I think about what would happen if there were broader access and as opposed to it being like a checkpoint or a box on a list that has to just get taken care of, it's seen more as an opportunity to explore what this process will be like, look like, seem like, feel like, what you might not have already thought of, what you might have already thought of. And like thinking about the more when you know better, you do better. I think but you touched upon Dr. Bindeman, you touched upon a really important point, and that is that the mental health component to the overall fertility journey, whatever that component looks like in each individual case, is most oftentimes not a profitable one. So then, full stop right there. We're admitting that because it's not profitable to do so, we are going to exclude or effectively exclude a
or
critical
divest.
piece of the journey because it's not profitable. I mean, doesn't this get to the deeper, darker underbelly of healthcare itself and where we really fall short? My gosh.
Yeah, I think, every industry is changing for numerous reasons, whether it is because AI or whether it is because of big firms coming in and sort of swooping it all up with the idea of efficiency. And I appreciate that. I get that. But what I have seen is my clients' experiences at these clinics have decreased. So when they're joining giant conglomerates, the experience decreases. Like it gets worse. So I always say to people that are in my area, I said, look, there's no such thing as a perfect clinic. Everyone I've heard of in this area, I've had clients who love it. I have clients who have hated it. No such thing. And then I ask, like, what is your priority? What is it that you need in this experience? Because if you need someone to kind of hold your hand and be there for you, I'm going to refer you to a different place than if you're like, I just want someone who has great numbers. Okay, I got that place for you. Or someone who's like not sort of in the box of infertility and treatment, like they need some more creativity or they need to be looked at in a different kind of way. They're going somewhere else because not all fertility clinics are the same, and that's okay. And Elizabeth, you were saying, I'm sorry, future Congresswoman, you were saying that it's not an incentive to bring on mental health, but even worse, it has been an incentive to divest of mental health. And again, you have these forms, and here these are people that like we know and we trust and go for it. I don't know again how often they are updated, so I know I have some some colleagues who are starting to retire. I don't know if they're still on those lists. Another colleague of mine from Duke did some research around the benefits of having mental health embedded in the clinic rather than adjunct or, a consultant we bring in sometimes. And part of the intangible benefits are, hey, if a nurse is having a really bad day, there's someone to talk to. If you have a patient that's having an emotional crisis because of needles, there's someone to talk to. If you're
You have a
having,
patient having a miscarriage after their 10th round of IVF and they finally got a positive pregnancy test and now there's no heartbeat. And where do
yeah,
we send? I mean, I apologize for interrupting you there, but like, man, you really have to lay that wide open for people. But yeah, I mean, Anne Marie will tell you, I mean, we having to call people all day long and tell them they're not pregnant. And that's
so
the hardest. You got to make the hardest phone call you'll ever make 25 times in a day sometimes.
yeah,
Mhm.
And where are you supposed to turn? It's like I think about I don't want to get too far off track, but I was recently talking to some veterans about the suicide rates in the veteran
so
active duty military and in the veteran population. And I said, but that's the system is designed exactly for that. Because what else would you expect people to do? You send them off to war in their formative reproductive years. You give them not great training. You definitely don't give them the mental health support, the social support that you need. It's a very like raw type environment, a performative type environment. They go off and do very scary things that normal human beings are not programmed to do. And then we put them back into society and we're like, hey, great luck. Good luck to you. Thank you so much for your service. Are you
yeah.
joking me? Of course, we have a veteran suicide crisis. We've done nothing to support these people. So I think about that and the way that parallels this, like, because you guys have talked about this with the rates of divorce and the different sort of social pitfalls or whatever you would call them as a side result of infertility treatment. Well, yeah, it's like no duh that if you don't build systems and processes drive behaviors. I say that all the time. If there's a system and a process to handle these types of things in the clinic, imagine how much of a better outcomes driven service we could provide. Like, how do we get people to truly buy into this?
I really wish I could tell you. I think a lot of it is just normalizing mental health. And like what I have always espoused, like since I was a baby psychologist, was we should have an annual mental wellness checkup, just like we are expected to have a physical.
Yes, yes.
To me, that just seems like, okay, at least you're in touch with someone.
Mhm.
Dr. Bindeman, I'm going to tell you and our listeners live on the show that when I get to Congress, I intend to sponsor legislation to make that so. There is no reason under the sun that we should not provide that type of service. Look at what's going on with the Epstein files and this massive ring of people that were abused. If they had had a Dr. Bindeman in their life to do that annual eval, gosh, we could be such a more powerful and harmonious society, right?
Or if
Gosh.
we have someone we've done those kinds of quick check-ins with and they haven't come in a couple years, at least it raises the flag up.
Yeah.
What has happened to this person? Just to be like, hmm.
Yeah.
So
Wow. Well,
So,
you heard it here first. We're going to make that happen because that seems those of you who know me know that I'm married to a mental health professional and it's wild to me. I mean, I grew up in a family where my stepmother had a lot of mental health problems and that was like the days of like shock therapy and stuff like that. Those of you watching the video version just saw my dog join us momentarily and leave.
Hazel.
She's a star on the show. But yeah, I mean, you talked about normalizing mental health. So how do you see give us some good news. Do you see positive trends when it comes to the normalization of mental health and
I've seen some good campaigns on it. I don't know what the impact of it necessarily was or is. So some states have done campaigns, some psychological associations have done campaigns. So like that's trying to get it out there. I think for some cynical people, which I completely get in this day and age, that the thought about it is, oh, you're just saying this so you can earn, you stand to benefit from this. So that's why you're saying it. It's like, no, I can only see so many people. I'm okay, but I still think this is really important because there is a systemic impact within just the family of not receiving mental health care. So if we think about trauma and we think about like the women who are survivors, they've experienced a whole lot of trauma. If they are not getting the mental health care that they need, it is likely that they will engage in similar patterns with their children. I'm not saying they're going to harm their children, but some of the dynamics of like, I am bigger, stronger than you, and or just having moments where mom just kind of freaks out and the kids are like, I don't know what to do with this. What did I do? So there is an intergenerational component too. And it would be lovely if we didn't pass that on.
Yeah, I've been reading recently about how Gen Z is how they're up and coming. I mean, you're probably starting to see Gen Z patients coming through infertility because they're in their early to mid 20s now. And being Gen X, we were kind of like your emotions are supposed to be like set aside, and we don't cry, and I cry all the time. But we're supposed to push that down kind of thing. And older millennials as well kind of got that same kind of messaging. But it seems that the Gen Z people are more in tune with their mental health, or they at least pay attention more to it, or they want it to be addressed.
And isn't it ironic that Gen X is the one raising Gen Z?
Yeah.
Just saying.
Yeah, exactly.
I got two Gen Zers, and Generation Alpha. So that's a whole different.
Yeah. So talking about this generational thing, I also want to talk about the component of men and how they are kind of dealing with infertility. Do you see majority of your patients, are they women? Are they couples? Or how many men do you have that you focus on?
I have less than a handful of men on my caseload right now, which is not atypical. I do see some clients, and oftentimes the idea of couples therapy is we'll do this a little bit, and then I'll just leave my spouse to be with the therapist.
Uh-huh.
Yeah. So it like starts as couples and then it becomes individual because now this person, has a connection, has rapport, doesn't have to do the hard work of finding someone. So it becomes sort of a natural handoff in a way. You have several couples that this is how I started to see them. I think as a society, we have not committed to how we want to see men. And so there is a societal cultural battle right now about what a real man is. And I imagine my definition is probably really different than a lot of the listeners' definition, and that's okay. But by only attributing men to that classic kind of male stereotype, we don't give them space or room to look or discover that actually you can go beyond the stereotype. And that's really okay. So on that micro level, I'm teaching my son that like, no, you do not have to be macho and stoic and all of that. My husband's fabulous. We are watching Shrinking, I'm obsessed with it.
Such a
Um,
great series. So good.
we were watching the last episode of season 2, and it is such an emotional episode, and they do it so well. And my husband just bawled. And he doesn't he's like, yeah, since I've had kids, I've been much more teary. But he was just like, oh my God, what a roller coaster. Oh my God, I was so scared for that man. Oh my God, I thought he was going to kill himself. Like he really could feel it. And I think that's beautiful.
It is.
Yeah, it is. I mean, I just go back to a story. I think it was Toy Story 3. Was in the theaters. Went to take
See
the
would
kids
come
to
to Toy
kids
Story
movie.
3 from this.
Yeah,
This
Toy
is
Story.
really predictable. Go ahead.
My husband and I are crying. We all know the scene. They're in the incinerator holding hands. My husband and I were both like sniffling and crying. Look over at the kids and they're just like, whatever,
Okay.
watching the show. I'm like, cold-hearted people over there. But yeah, I mean, there are things. My husband also as well gets very emotional on some shows as well. But that one was like we both were like, oh my God. And I think that having that and showing that other men can have emotions, absolutely brilliant.
Yeah, I think I know you can't speak to any specific studies or things like that in generalizations, but it seems like we are getting better, even though there's a lot of resistance, right? And that's mostly the white nationalist influence who wants to tell you how to be you as opposed to
I think it's a
autonomy.
lot of traditionalists
Yeah,
that afraid of
exactly, where it's kind of one of those things where it's like, "Okay, but why?" Like, and I think when you are brave enough to step up and say, like, but, like, even with my son, "But why do you have to be brave here? You're allowed to," like, or did you hear or were allowing children or allowing young people to think through complex situations was not things that we necessarily, like the 3 of us, had available to us when we were being raised. And I believe, like, each generation's parents does the absolute best they can with what they have because the events of the time are what shape, right? Like, I think about our growing up, we're all 3 of pretty similar age, I think, and, our high school was marked close to or around when school shootings started at Columbine. We just have had a lot of formative events that have made us more who we are, and it gives me hope when I see how in touch younger folks are with these things and hoping that, again, when you know better, you do better. And it gives me hope for the future that if we can cultivate this, we'll be okay.
I think part of also what you're talking about is there was a different kind of mental health within the country in some of these past times
Yeah.
where there was truly a sense of like, this is not okay. School should be a safe place. This is not okay. I was in second grade when the Challenger exploded, and we were having lunch in the classroom and watching it live on TV.
Uh-huh.
And then our teachers abruptly turned off the television. And it's sort of like, how do we figure out how to talk about this with a room of second graders? Just like we didn't know what we saw. We're like, oh, what happened? And so just having to explain this is something that we're so sorry happened. And also trying to get the news, and getting that news was metabolized differently. It's listening to a radio or waiting until the live news is on television. It's like totally different way of getting information. There's no text chains going back and forth, nothing like that.
So you
And
were
so I
waiting for the newspaper to show up in the morning to figure
Yep,
out
Mhm.
what happened. I mean,
yep.
it
But
it
it
that seems outlandish to young people today.
but it's the reaction that we had as a country about it,
Okay.
where we all mourned the astronauts. And
Yeah.
that was a collective thing that this country has done. We did it after 9/11, where we really were able to be like, okay, we are mourning that this horrible thing, this scary thing happened to our country. I didn't see that as much at the beginning of the pandemic. That's where there was a lot, and, like, that is also a traumatic experience we had. Whether people had to be on lockdown or not, it was traumatic, and we
No,
had
there was this scary invisible thing out there, and
yeah,
we spent our days watching body counts on 24-hour news channels,
yeah.
and that's not normal.
No, no. It's again, it's scary. I think about it too, like people who are going through fertility treatment at that time. Is their clinic open? Is it closed? Some clinics were open, some were not.
Yep.
It wasn't deemed to be necessary
Essential.
healthcare. And so that also shaped some decisions. And I have a wonderful colleague who did some research about what patients' experiences were during COVID. And they did not have good experiences.
No, it was terrible. I mean, we were flying by the seat of our pants. I was running one of the nation's busiest IVF travel programs in the country during COVID. So, I mean, and that was based out of New York, and New York State has a reputation nationally for following health guidelines pretty firmly. So we were kind of like it was like being a start and stop in a golf cart because it was just like we'd think we have clearance to start something and we wouldn't. And then yeah, dealing with people trying to say like, well, I'm sorry, the state of New York doesn't consider this to be essential. We can't have a ventilator for you, as a backup. Like it just was so complicated because it became just another barrier to entry. And this time it was so, yeah, like start and stop, up and down, jerk, whiplash kind of action. I would be fascinated to read that research, just having been deep in patient care during that time
Oh,
for
yeah.
a group that was heavily affected by those mandates.
Yeah,
Yeah.
having to delay their treatment, the time they
Yeah,
didn't wanna
just
lose
that
that time.
alone, just even a couple of weeks is devastating.
Yeah, like if you're mid-cycle and then it abruptly has to stop, or you are supposed to transfer and now you can't get to the clinic on time. So it's the expense of it, it is the uncertainty of when the next one will be, it is the anger that this is all happening. And so I think like there another collective moment in terms of infertility treatment and patients that is more recent is Alabama and that state Supreme Court's decision that embryos were people. And I was working with someone in Alabama and she was mid-cycle. And so what does that mean? And I've seen a lot of wonderful advocates speak out. And I recall one who has a transplanted uterus and like needed to have her second now. It was not something she could wait on, and how like it was a ripple effect because even trying to move your embryos out of the state,
Was a
people wouldn't
nightmare.
do that. Yeah,
Yeah.
it was so,
No, the whole industry was, like, ironically frozen because it
yeah,
was the implications suddenly. I mean, just like some of these backdoor abortion bans that we see moving through our state legislatures last year and then again into this year, despite overwhelming public support, we see this kind of stuff continue to shape the actual experience of the end user, the patient, the person whose life this is on the line, whose future family it is on the line. Gosh.
yeah. I read a study yesterday. I'll have to find it again, but it was about consequences of jobs and looking at it from a maternal mortality and morbidity perspective. And most studies, when they look at mortality and morbidity, they don't include suicide and they don't include substance abuse. But this study did. And so the rates are actually much higher than the high rates we think they are. And it's, again, like I'm brokenhearted about that because when people don't have choices, the oldest way of coping is with alcohol. We're going to drink our troubles away. So, yeah, like that becomes a real thing that people fall back on. And it's everything is so multifactorial and everything comes back to being related to mental health because any situation we're dealing with, two people going through the exact same thing experience it differently based upon what they already know and how mentally healthy they are. So if I have two people that have gone through IVF and they just learned that none of their embryos made it, like couldn't even make it to blast. Someone that's more mentally healthy will be like, "Oh, this is really sad." And will have that sadness and then is able to look at it and be like, "Okay, let's see what's next. Let's see what we might want to think about." Whereas others can get really stuck in that sadness. And so the stuckness and sadness is really different than grieving and being sad. There's nothing wrong with being sad. It's when we get stuckness in it. That is the part where I get concerned with people.
Well,
Yeah.
I mean, all the more reason that we need to continue to amplify how I mean, and I think you said so it's just like it's a lot on our nervous systems all at once. And I think we could acknowledge that. I mean, we have a therapist among us here, Anne Marie. Like, I mean, we have a little bit more time till we wrap up. So let's talk a little bit about the mental health impact of what's facing us as a society. It's a really big question, but how you see what's ahead of us as it relates to our mental health, because I think we are just inundated with traumas
Yeah.
and traumas and traumas and traumas. And it's like, we're going to be studying this in 100 years, like the collective trauma that shaped us. What say you about the mental health components of what's happening today?
So before I get to that, I realized I didn't actually answer Anne Marie's question about men and infertility. They often feel very unseen, like their one job is to ejaculate and on demand, or their one job, if we're doing a time cycle, is to have sex on demand. And so that can certainly cause performance issues. It can cause self-doubt. Is this my fault? When it is male factor or male factor is playing a part in the infertility diagnoses, It's that sense too of like, this is my fault and she should find someone else. And I was supposed to give her children and I'm not able to do that. Interestingly, women feel the same way. And when they actually talk about it, that's not something that happens. They're not like, okay, I'll leave you and I'll find someone else I can have kids with. It's, we're going to take this on together.
Mhm.
But men tend to be, or even more broadly, partners tend to be forgotten.
And I've heard that anecdotally a lot. And I have a close friend who would attest to that. He not only did he feel that kind of unseen, unheard component when it was IUIs and when it was time cycles and then IVF and but then beyond that, even in the NICU, the dad is often kind of everything is directed at the mom and the baby. And listen, we're going to be the first ones as women to say, "Good, yes, thank you, yes," and
Now, this caretaking role that
yeah,
a dad in the NICU is taking on, where he's caretaking for two, and in fertility, there's a caretaking role.
that's
And
right.
what I hear from so many of my clients is they would love for their partners to do the logistics of it. Like that just becomes another mental load to carry.
Yeah,
The same time, should they let their partners do it, they become upset because
right.
no, this doesn't work for me. And how could you schedule it then? So oftentimes partners really are in a bind. They try to offer to help with shots. I don't think they know if they are supposed to come to appointments or not. Like they'll come to transfer, that's one, or come to face consultations. Okay. But not all of those other visits.
I would get questions from patients. I'd be like, "Can my husband come to the ultrasound?" I'm like, "Yeah,
Of course.
totally."
But it makes men feel disposable. And because this is a world that their partner has researched and researched and researched and researched, she has much more information about it. And so when he's sitting with the doctor, she's asking questions because he can't ask, I don't understand what that is. Tessie, what does that mean? It's what? But because they don't want to feel stupid in front of a doctor. And so, like, there's that stigma. And so that's another reason that men sit back, not because they want to necessarily, but because by societal expectations, they feel like they're forced to. Okay, now going on to the bigger thing, because yeah, our mental health is being impacted. I live right outside of Washington, D.C. So much of what's happening impacts me and my community, my friends in a different kind of way than it might impact someone who is in a different place than I am. Because, yeah, like when we see federal shutdowns, that impacts a whole lot of people. When we see mass firings in the federal government, that impacts a whole lot of people. And I think we don't necessarily know the full on mental health issues that are going to come. But should these plans all go as Project 2025 dictates, or even Project 3030, also really scary, or 2029, sorry, really, really, really scary. I don't think people will really mourn what gets lost until they feel it. And so there's going to be some people that already have started to feel their insurance and what it means for making a decision of, can I pay for my insurance versus food on my table? So there's a lot of things that are happening now and that can and will happen in the future. So some of the scary stuff that's sort of being presented on a state level right now is going after birth control, saying it causes abortions or it's bad for health or whatever it is that they are attributing that has been proven over and over and over again that it is not. And I think because it is a step in having this country be like it was on Leave It to Beaver. So you have a man and a woman and they're married and the woman stays at home and she raises the kids and she cleans the house and the man goes to work and gets to be all of that undesirable that gets reinforced in what a man is. So I think like there are really broad implications. And like, what does that then feel like to people? I remember when I had my first kid and I had maternity leave and I was going nuts because I just didn't feel stimulated.
Mhm.
Like it was boring. I knew what to do. I just didn't feel stimulated. So by my third kid, I was proofreading chapters that I needed to submit for publication because I'm like, yeah, I got this all down. We're fine. But it means that women are now seen again as second-class citizens. And that is alarming, and that we don't get to see our lovely same-sex couples because they're having a wonderful life just like the rest of us. They're having hardships just like the rest of us. Why do we need to make it harder for a smaller community? Although that is kind of what the playbook is we start with the most marginalized community and we move up to the next marginalized community. It is inconceivable to me that all of the things that are happening are happening. It is also incredible to see how some citizenry responds to it. So the people of Minnesota, wow, their nonviolent protest. Wow, the discipline you need. Or neighbors helping neighbors. Wow.
Yeah, we had would have been incident down at the the ICE office in Phoenix is a common site for protests, far more so since the killing of Renee Good and then Alex. And apparently last week I heard from an organizer that there was an instigator that had been sort of driving around the area and trying to instigate the anti-ICE protesters. And a man started walking onto the scene, kind of had a big flag and was intimidating. And she just walked up and hugged him and said, "I'm going to keep hugging you until you leave."
Amazing.
I mean, mind-blowing story, right? Like, I'm just gonna hug you until you leave, right? They want to paint anybody who is anti-ICE or this administration as these violent people, and yet I'm gonna hug you until you leave. I don't know if you three have heard. I might have brought this up last episode, and if I did, I apologize. But Lady Gaga did an absolutely brilliant remake of Won't You Be My Neighbor. And I listen to it now when I go canvassing because I believe that if we could take on this modern day Mr. Rogers, I mean, that's the form of America that we're going for, guys. Like that
Yeah.
is what we're going for. And so I love that you said that. And I think that that's probably a pretty decent spot to wrap up. This has been a really fascinating conversation about every angle of mental health, not just fertility. But Anne Marie, do you want to leave us with any final questions for Dr. Binderman? Dr. Binderman, or thoughts?
I think we're going to have another episode with Dr. Rinderman for sure.
Yes.
There's so much more to uncover and so
Yeah.
much more to peel back for sure. But being that Dr. Binderman is in the Washington, D.C. area, just wanted to bring up the fact that, Elizabeth, you are going to Washington, D.C.
Tiffy?
Yes, on February 28th. Elizabeth, you want to tell us a little bit about your event?
Yeah, we're taking the campaign on the road, our first little road show. Well, second, I guess. But we will be heading out next Wednesday to Boston, where we will be having a fundraiser sponsored by the Healthcare in Action PAC. And that PAC exists to get healthcare providers elected to Congress. So if you're in the Boston area, please go to our website, send us a message. We would love to get that invitation out to you. But then we'll be traveling via train south through Philly. My chief of staff is from Philly. She actually temporarily relocated to Arizona just to run this campaign. So we're going to be stopping in Philly and seeing her family, and then going down to DC, where we'll meet up with you, Dr. Bindeman, with Barb Kalura of Resolve, and all of our DC area friends, family, federal colleagues, etc. Everyone that is fed up with what's going on. My campaign does have a solution to offer you. And so we would love you to join us at either of those events. Dr. Bindeman, I was thrilled that you were the first one to get on the list because I
Yes.
very much value your perspective in these spaces. And I think it's just gonna continue to grow. So yes, looking very forward to that next week, a Thursday night, the 26th in Boston. If you're in that area, look us up. And then on the 28th in DC, there are going to be two amazing events. I guess this will be our first public announcement that Elizabeth Carr will be joining us in
Oh, nice.
at the Boston one. So for those of you listening who don't know, Elizabeth Carr
Very cool.
was and will forever be the first IVF baby born in the United States, an incredible advocate. And so I'm just over the moon at the number of people that are coming to support this new vision of our future together. So thank you for the shameless plug for our fundraisers. But no, listen, in all seriousness, if you don't want the same government that has been failing us, then we need you to come out and fund these fundraisers, because otherwise you need money to run a campaign. And so then politicians will go take money from corporate PACs, and then those PACs will dictate how your member votes. And that's how you end up with representation that doesn't actually represent you.
I
And
would
so
love to spend the rest of the day talking to both of you, which so easily we could, but unfortunately, I have a client now.
she has a patient to go see. Of course she does. So
We just gotta
that,
follow.
that's a wrap. We appreciate you. We truly could spend hours. Go see your patient. We'll see you guys on the next episode.
All right. Thanks,
Bye.
everyone.
Bye.